We've also noticed that there's a high number of patients who get admitted for things that they wouldn't need to be admitted for if we had a better handle on all of their medical issues.
We've increased dosages on patients that were not compliant or adherent to their medications, and then inadvertently we had overdoses when they finally did take their medications.
Approximately 1.5 million people are injured each year due to the incorrect usage of or lack of access to medications, and nearly 25% of ambulatory patients experience some type of adverse drug event. The Institute of Medicine has stated that the safety and quality risk associated with medication use in the United States is severe. Putting aside the toll of this issue on human life, the IOM has declared that for every dollar spent on ambulatory medications, another dollar is spent to treat new health problems caused by these medications. Ineffectiveness of our systems of care has been identified as one of the primary factors contributing to these unfortunate outcomes. While defined over 40 years ago, the patient-centered medical home is an approach to providing care that has recently gained renewed interest as one solution to facilitating a patient's ability to receive optimal health care. It's a model being discussed heavily by government, health plans, and professional societies. But when you drill down from these high-level conversations, what will it look like when a team of health professionals adopts this philosophy as a way to improve care delivery and specifically medication use? Eastside Family Medicine Clinic in St. Paul, Minnesota is one place where an interprofessional group of staff is adopting the medical home model and finding ways to improve the use of medications across the system.
Well, ultimately, our goal would be to have the patients being empowered about their health care and making sure they know how to use their medications. That would be the ultimate goal.
One of the principles of the patient-centered medical home is coordinating and integrating care. An early area of emphasis for the Eastside Interprofessional team was enhancing the engagement of pharmacists in medication management.
As part of the medical home model, in connecting people to the pharmacy, I'm able to walk them down to the pharmacist and say, this person needs this or that, or could you educate them more on their diabetic medications? They're kind of confused, or do you know where they can get it cheaper?
Some of the pharmacy initiatives that we've done here are medication reconciliation, especially with ER follow-up patients, and especially with patients with chronic healthcare diseases. I've been following up with them and making sure they come in to see the pharmacist so that we have more coordinated care visits.
Well, so we have collaborative practice agreements here that do really affect my efficiency with the patient. It allows our pharmacist and one of our clinical nurses to basically make medication adjustments without necessarily having to see myself, and it allows patients to come in and be seen by the pharmacist or by the nurse and make little adjustments that really saves time for me in the long run and is better care.
An area of focus for the medical home team was moving from a reactive style of practice to one where the staff consciously discuss medical issues prior to when the patient arrives for an appointment.
Well, when we're talking about the tyranny of the urgent, we're talking about when patients come in with a list of an agenda items. We oftentimes miss getting to really crucial issues from our perspective of their health care. We can now proactively prepare before the patient comes in and say, I talk to the pharmacist or the nurse and say, we get together and say, well, this patient hasn't had this key crucial diabetes test and they haven't had their feet looked at, and we're going to somehow be able to fit that in and have a plan our visit out before they get there.
Kenny is one Eastside patient with complex medical needs and a history of requiring urgent medical attention. Patients like Kenny are the initial focus of Eastside's medical home efforts.
Kenny has definitely improved as far as his coordinated care visits, especially with seeing the doctor and seeing the pharmacist on the same day visits, as well as the diabetes educator. So his diabetes has improved greatly, as well as decreasing how many times he's been in the ER.
So the medical home model, I can foresee in the next 2 years that people would have access to the clinic in a easier fashion, that we would be providing for their physical, mental health, spiritual needs. We'd be treating them holistically, and this would be like a one-stop shop, you know?
It became my health care home for me and my whole family, which it has.
for Open Cities Health Center in St. Paul, Minnesota, the decision to adopt practices consistent with the medical home model resulted in a different focus for its work on improving medication systems. Like Eastside, Energy has been committed to improving interprofessional collaborations, as well as integrating a clinical pharmacist into the work of the healthcare team. A byproduct of data collection and reporting required as a part of a medical home implementation grant has allowed the team to recognize patterns they would not have otherwise understood.
We looked at our diabetic patients who also have hypertension. What we found is that their diabetes was well controlled, but their cholesterol was either not adequately measured or that it was under controlled.
Some of the things that we've done that we've incorporated here at Open Cities to address the changes that we need to make, really to provide better care and come up with better outcomes for our patients, have been to really put the pharmacist in charge of managing their lipid levels and both in terms of outreach, contacting the patient, talking to them about the services we provide, what we hope to offer them, the importance of their controlled conditions, as well as then having them manage, or having me manage then the medication use around this condition. It wasn't just a matter of me recruiting them to come to clinic. It was really a matter of then following up and coming up with a care plan that is appropriate for each individual patient.
The one thing that was missing was the pharmacy piece. The PharmD, educating the patients and working with our nursing staff and our doctors to making sure that the medications, because these folks are on multiple medications, that it's all correct. And they come in here with bags of stuff that they've been taking, what they think helps this or that, and so many times what they're doing is not right.
In addition to discoveries made through enhanced data reporting and analysis, the medical home activities have also helped establish a commitment to improving quality and safety in other areas of the clinic's medication use system.
Open Cities has really turned to the pharmacist here to lead the changes in the medication use systems. Everything from changes that take place here in the sample closet to system changes for patient care, and spanning to data measurement. So it's been a really comprehensive role.
As the spotlight shines brighter on the problems associated with medication use, healthcare organizations will be under greater pressure to improve in this area. Eastside and Open Cities clinics have recognized the need to address medication use within their medical home initiatives and have determined that they must include pharmacists as a key member of that model. As you look into the future of service delivery within your organization, what changes might you make to ensure optimal medication outcomes?